Before we begin, I wanted to review a few tips for the Wova event platform we're using today. If you're using Wova, it makes it very easy to access event features, including a web portal or through the mobile app. You can explore the agenda to view upcoming sessions, use the community tab to view topics, and start or engage with conversations with other attendings. We heard from our presenters today that they actually have been engaging with others, so it's great. Also, be sure to check out our sponsors who supported this event and view their offerings. Closed caption is enabled. If you'd like to view subtitles or a running transcript in a separate window, you can access them via the live transcript icon on the Zoom control bar. Today's session is being recorded and will be posted on the CTRC YouTube channel by the end of the month. With that, I'd like to introduce the first of our guest speakers today. That is Claudia Burdisso. She is a language access consultant at AvantPage. Claudia is an active minority group advocate with over 14 years of experience working within language access. She specializes in advising government agencies on programs to expand access and quality inequity. Next, I'd like to introduce Eduardo Diaz. He's an account manager also at AvantPage. Eduardo has strong project and account management interests with a focus on legal, healthcare, government, and election translation solutions. As a bilingual account manager, he helps partners optimize their services and programs by providing meaningful language access at all levels. Eduardo, Claudia, the floor is all yours.
Hi, Erin. Hi, everyone. Thank you so much for those kind introductions. Eduardo has started sharing the screen. Okay, here we go. As Erin mentioned, today we will be talking about language access, engaging, building trust, and reducing barriers. Just very briefly about us. Personally, I have been involved in the language industry for over 15 years. And in AvantPage, I have been for 6 years. I'm the business developer manager, and I work mostly with ELP and people experiencing disability. And we have my dear colleague here, Eduardo.
Yes, thank you, Claudia, and thank you, Erin, for the introductions. I think just as a complimentary note, I'm very happy, of course, to be connecting with you all. And I've been working in the language industry for over 7 years, focusing primarily, consulting for healthcare organizations here in the state of California. So today we have an exciting agenda lined up for you, focusing on 3 main topics that are crucial for achieving equitable and accessible healthcare through telehealth. We'll first examine the status of telehealth and language access after the pandemic. We'll then dive in a bit deeper into the specific challenges that language barriers present in the context of telehealth. And in the end, we'll just highlight the importance of addressing disparities in a digital access context. Our aim here is really to equip you with valuable insights and practical strategies to effectively engage with diverse populations through language access initiatives. So to begin our session today, we have posted questions through the Wova app about interpreter usage and about language barriers, and we're going to be posting it here in the chat as well. If you could let us know your thoughts, and we'll try to bring it up on the conversation as we go forward. So yeah, let's get right into it. It's really no news that the COVID pandemic has dramatically accelerated the adoption of telehealth. And as we look into the future, it is clear that a combination of both virtual and hands-on care will undoubtedly persist beyond the pandemic. So just for instance, prior to the pandemic, the number of telehealth video visits was already growing by 30 to 50% per year, according to the Commonwealth Foundation. And the growth experienced during the pandemic demonstrate, of course, the widespread acceptance and the perceived value of telehealth overall. And although it has now stabilized compared to the early days of the pandemic, telehealth usage still continues to remain above pre-pandemic levels, as you can see on the screen. And I think in general, that's also because the pandemic provided, in a way, a springboard for telehealth use as a necessity to deliver care, while social distancing, of course, impacted all aspects of healthcare delivery. Several reports and studies have actually demonstrated that telehealth provides opportunities to make healthcare more efficient, better coordinated, more convenient, affordable, and that it overall removes barriers related to location, transportation, childcare expenses, some productive time away from work, so on and so forth. So that's, of course, a very positive note. And I think another thing that really helped increase the adoption of telehealth was the fact that with the declaration of the public health emergency in March 2020, it resulted in a rapid expansion of telehealth services that came along with a relaxing of regulations at both the state and national levels. And the public health emergency also gave rise to expanded insurance coverage through the Families First Coronavirus Response Act that was enacted by the US Congress, and also brought expanded Medicaid populations that could use telehealth. And when talking about Medicaid, of course, it's worth noting that Medicaid not only saw a considerable increase in enrollment during the pandemic, but also had one of the highest rates of telehealth visits according to the Office of Health Policy. Some other regulatory aspects that came along with the pandemic included expanding technologies used to deliver telehealth, such as non-HIPAA compliant technologies. It also allowed new care services to be delivered via telehealth, and overall broadened the provider types that may deliver services via telehealth. So I think this context is, now that things are coming back to normal with the end of the public health emergency earlier this year, it is critical that we ask ourselves, how can we anticipate and address barriers to equitable and accessible healthcare? And when it comes to underserved populations, and particularly those who speak languages other than English, it's critical that we acknowledge that reliance on technology, of course, it's great and very positive, but can also widen the gap in access to care for these populations. And to provide some perspective, individuals with limited English proficiency have historically experienced gaps in healthcare related to difficulties in comprehending and communicating healthcare information, to accessing high quality, reliable care, inability to access important medical information, longer hospital stays and inaccurate diagnosis, increased risk of delays and errors due to language barriers, and overall barriers in navigating the system itself from an administrative perspective. So although there has been great advancement in technology developments more recently, there has been unfortunately minimal progress in addressing healthcare access and equity for limited English proficient patients. And I think in order to start addressing a solution, it's really important to get back to the basics and try to understand what is it that we refer to when we refer to limited English proficiency.
Thank you for that introduction, Eduardo. When talking about language access barrier in virtual health, ELP, limited English proficiency, is a crucial concept that comes up very often, and it's widely misunderstood. The common misperception is that an ELP is someone that doesn't speak English at all, but that's not a broad enough definition. When you ask the question, how well do you speak English? An ELP's answers might range from not at all, not well, well, and even in some cases, very well. Communicating effectively in English for people who speak English as a second language is not only a matter of the vocabulary or the subject, for example, legal jargon or health literacy, but it's also affected by the stress of the situation. Stress and trauma can have a big impact on someone's ability to effectively communicate in English. And I'm going to tell you a bit about a personal story. Well, my first language is Spanish. I'm from Argentina, and I moved to the US in 2012. The first time I went to the doctor, I went to the University Health Center. I was already fluent in English. Now I asked me if I needed an interpreter. I didn't ask for one. And when the nurse and the doctor started asking me questions, I felt a bit uncomfortable. I wasn't clear on what they were asking me. I tried to communicate my previous experiences with them, and I wasn't sure they were getting it either. So at the end, they gave me a diagnosis, they gave me a prescription, and I was still unsure if they really understood what was going on with me. And besides the language aspects, if at that moment someone would have asked me if I needed an interpreter, I would have been hesitant because I would have thought, oh, they're going to charge me so much money for this. Am I going to have to pay for this myself? Or how many hours are they going to make me wait for an interpreter? Or is this going to be confidential enough? So there are a lot of other questions to this aspect of working with ELP patients. The reality is that the number of people in the US who speak a language other than English at home nearly tripled since 1980. It used to be 1 in 10 in 2019, in 1980, and then in the latest census of 2019, it was 1 in 5. With the current migration patterns, it is not surprising that ELP individuals are the fastest growing demographic in the US. And almost 45% of Californians speak a language other than English at home. California is the state with the most ELP individuals in America. While telehealth has the potential to close gaps in care, there has been limited use of telehealth services among ELP patients. And here I want to make the clarification that I'm talking specifically about video telehealth. There are some sources and some studies that suggest that audio telehealth might not be most adequate for certain situations, such as situations that require visual monitoring or visual diagnosis that are important to care. But coming back to video telehealth, according to a Kaiser Permanente study, ELP usage of video telehealth is far behind. It was only 2% during the pandemic, and that 2% that doesn't represent the 20% of the population that says that are ELPs. Telehealth is here to stay, and ELP inclusion is crucial to work towards health equity, and we need to bridge these barriers in care. People whose primary language is not English often face hurdles to health access. So we have identified 3 main aspects. The first one is access and utilization. This one relates to the lack of devices and technologies that supports the integrations of interpreters in hospitals. For example, the portable tablets or having a steady internet connection. Sometimes there is also a lack of understanding from providers on how to use technology or how to collaborate with interpreters. The second aspect is the visit experience. This relates to the cultural sensitivity and understanding that can lead to poor patient experience. When we are talking about high quality, equitable care experience, there is not a one-size-all-fits solution. It really requires a deep understanding of the members' cultural needs. The famous sentence here, meet them where they are at. And the third aspect is the visit quality. It is proven that the lack of qualified interpreters reduced the ability of ELPs to receive safe and comfortable care during the pandemic. But the experience doesn't end there with the patient's visit. Then we must take into consideration the continuity of care. For example, printed instructions in the ELP preferred language, prescriptions, and more. So to bring down all these academic concepts to the actual experience of an ELP patient, we are going to tell the story of Miss Tu. Miss Tu is a 62-year-old Vietnamese-speaking patient with minor asthma and back pain issues who is otherwise physically healthy. Before the pandemic, Miss Tui started group counseling sessions after feeling depressed and isolated. Due to the pandemic, the counseling sessions were instead through the clinic's virtual telemedicine platform. This platform was not translated into Vietnamese, and there were no instructions in Vietnamese on how to access it. Miss Tui was not tech savvy either. For the first virtual session, her daughter helped her. She was able to access the session, but for the second one, her daughter was busy. She was not able to help her, and Miss Tui was not able to access that session again. As a consequence, she stopped attending those sessions that were making a difference in her life. At some point, her depression worsened. She moved out of the state to live with his son, and at some point, she started having suicidal thoughts. When she called her provider, she realized that the provider was not licensed in that state, so she could not continue care with the same provider that has been treating her.
Thank you, Claudia. And I want to add that the unfortunate story of Mrs. Tui here is representative of the LEP patient journey that leads to negative health outcomes. And I think it's important to recognize that the lack of inclusivity in systems and platforms added to lack of language services or language or qualified language services within a healthcare context poses significant challenges to the continuity of care for limited English proficient patients. We certainly must recognize these issues in order to work towards implementing solutions that really prioritize equitable access to healthcare information and culturally aligned communication. And I think the question, of course, is, well, where do we go from here, right? We have so far discussed and identified some of the barriers that limited English proficiency poses to accessing high quality, reliable care. And we wanted to share some strategies that you can apply today to start improving patient outcomes, patient-provider relationships, and overall foster a healthcare system that truly serves all individuals regardless of their language proficiency. And so we have identified 3 main pillars that can serve as guidance to improve care delivery for these underserved populations. The first one has to do with building organizational accountability. And this is by establishing culturally and linguistically appropriate goals, policies, and promote them across the organization planning and operations. So this can have to do with, from developing language access plans that set the tone and standards for how culturally competent care should be delivered, to dedicate staff and resources with the sole responsibility of monitoring, planning, and implementation of language access, to collect and maintaining LEP and demographic data in order to be able to monitor and evaluate the impact of language access on health equity, and overall to be able to address LEP-related issues and complaints. The next pillar would have to do with advancing digital inclusion. And this is around educating and training not only providers, but leadership and staff on how to provide culturally competent and effective communication. but also directly with providers, supporting them with instructional materials on how to connect with interpreters and other necessary processes to be able to deliver care in a cultural competent way. On the patient side, it's also about supporting them with instructional materials on how to navigate the system, and of course, increasing the availability of professional interpreters. And ensuring that those interpreters can indeed be integrated to your systems and platforms in an appropriate way so that they can be connected in a timely manner when they are needed. The last pillar would be around reducing barriers by leveraging partnerships. So this one is all about prioritizing relationships to support care that is really reflective of the needs of the communities that you're serving. So this is about partnering with community-based organizations to help you conduct your outreach and to accurately assess the community demographics and needs. And also to partner with competent language service providers that offer a consultative approach. So they help you on how to most efficiently and effectively deploy language access efforts, and that ideally offer a one-stop shop service model so that they can help you meet all of your language access needs while also ensuring a streamlined internal process for your staff. So to bring it down to a more concrete set of guidelines, we also prepared a language accessibility checklist to sort of guide the journey to move the needle on health equity for limited English proficient patients.
Thank you, Eduardo. Yes, we are aware that we have provided a lot of information. Therefore, we want to make sure that we can also give you some guidance on how to get started to understand how accessible and prepared your organization is to work with the ELP population at this point in time. So this is the checklist that you're seeing here. The first question, what services are available? It's about understanding the different type of linguistic services that you can use in each situation. When talking about telehealth, some examples are over-the-phone interpreting, video remote interpreting, simultaneous interpreting, consecutive interpreting. Do you know which ones are accessible to you? What are the differences between these services? What's the preference of your ELP population? And the second question, what are the most common platforms related to technology? During the pandemic, there were some exceptions to the HIPAA restrictions and platforms such as FaceTime were used in some instances, but there are many HIPAA compliant platforms that can integrate with other third-party platforms. Do you know your options? And do you know the benefit of each of these platforms? The next question is, how culturally competent is your organization? Is your organization providing cultural sensitivity training to your staff? Do you have a plan on how to serve your ELP members besides just providing the information in their preferred language? The fourth question is, what data to collect? Data is pivotal to improving service offer. Some common data points are to track language distribution, dialects, the durations of each session, and the frequency. And the last but not least important question is how to source and assess vendors. Do you know what are the qualifications of the interpreters that they are assigning to your ELP patients? Do you know if their interpreters have received trauma training? Do you ask your ELP patients to rate the quality of the interpreting experience? Or how do you measure success of your interpreting services? Does your vendor have the availability for all the languages that your members speak, or are some gaps there? Do you have a back plan if the system goes down? that's something that unfortunately it happens still in 2023. It's still happening. So it's always very important to understand that to have a backup plan, and that's something that Eduardo and I see often, that it's not there even for big organizations. So we have, this is the basic checklist. We don't want to overwhelm you with too many questions. We have a more thorough form. If you're interested in receiving this information, just please drop your email there and we will send you the PDF with all the questions. We really hope that all this information was helpful for you. We have about 5 minutes to receive any comments, questions, or to hear about your experience. We have also seen some responses on the app, but before reading them, we want to open up the room for anyone that wants to comment or want to ask anything. Okay, we will send that to you then. And in the meantime, feel free to stop me if you have any questions, but I'm reading here the responses that we have put in that you have answered to the poll. And one of the questions is, what type of interpretation does your organization provide? Most people responded over the phone interpreting. The second most common answer was in-person interpreting. And then it's followed by video interpreting, and we don't provide interpreting. Now, there was an option that was family members provide interpretation, and nobody chose that one, and I'm very glad that that was the case. Then the other question was, what are the most common barriers that you have faced when interacting with ELP patients through telehealth? And the most common response was not having the appropriate technology to integrate interpreters. Then there was one response that said other, so I'm not sure who was that, but if you're here, feel free to open up the mic and comment on that one. And the third question was, what strategies have you identified to improve your communication with ELP patients? And the three responses were, this was an open-ended question. It was interpreters, telelanguage, and technology. So I think that's all from us. I don't know if you want to add any words, Eduardo. I think we have a minute and a half left.
No, just thank you all for the opportunity. Of course, let us know if you have any further questions. We'd be happy to, further engage through the app or just continue the conversation about this very important topic, and also look forward to Marco's presentation in a minute. But very happy to be here, and thank you for the opportunity to connect with all of you.
Yes, thanks so much, Claudia and Eduardo. Claudia, thanks for sharing your experience. You asked some questions I hadn't even thought about when I get an interpreter, such as the cost, the time, I guess like what people are thinking when you're like, I'm going to get you an interpreter. I mean, even like just assessing the quality, right? It's like we kind of assume because we hire somebody that they're going to be a great interpreter, but I think we've all been in a room where maybe there's some like friction that starts, or it seems so, and you're not really sure because either you don't know the language that well to kind of intervene, or you're like, well, they gave me an answer, so it must be, things must be going well. So I hope folks reach out to you via, obviously they're on Zoom, you can private chat them. I believe their email was in their presentation, but this was great and definitely gave me something to think about. Yeah, no worries. So we're going to transition to our second session as part of this hour. So the second session is going to be how telehealth can become a major player for Latinos living in California. If you're joining at this moment, just a reminder, this session is being recorded. It will be posted on the CTRC YouTube channel at the end of the month. Again, this is for informational purposes only. There's no relevant financial interest, arrangement, or affiliation with any of the organizations related to commercial products or services discussed during this telehealth summit. And with that, I'd like to introduce our next guest speaker. His name is Marco Paschilla. He's the founder.
Paschina, yeah.
Can you say it again?
Yeah, Paschina.
Paschina, thank you.
Yeah.
He is the founder and CEO of Telehealth. Marco is a serial entrepreneur with a deep passion for leveraging technology to solve large socioeconomic problems. He has built the largest online student loans company in Latin America and now serves the Latino community through Telehealth, a telehealth provider for Latinos living in the US. Marco, the floor is yours.
Thanks so much, Harry, and thanks so much, everyone. Thanks for the invitation. I'm really excited to share more of the work we're doing and how can telehealth become a major player for Latinos in California. So I'll give you a quick overview of myself. Yeah, I'm actually an entrepreneur that has dedicated my whole career in building companies that leverage technology to actually solve large socioeconomic problems. So my first company is called Creti, and Creti became the largest student loans platform in Latin America. We financed all the students that couldn't get into college because they couldn't get a student loan through a bank, right? Because their banks, it's really hard in Latin America to actually get a student loan. It's very different from here in the United States. So in a very short amount of time, we grew extremely fast, and we really, to give you an example, banks accept 12% of their loans applications. We were accepting more than 50%. So we really helped many students that couldn't get into college actually achieve a college education. And then I decided to come back to the US and continue to serve the Latino community, but this time through healthcare, right? Latinos here in the United States have a lot of troubles accessing healthcare, especially the ones, that maybe are not born here. And so at Akenta, we hope to help the Latino community solve this problem. So what do we do in Akenta? So in Akenta Health, we offer a provider as a service to safety net providers. So we basically help FQHCs, rural health clinics, and other healthcare organizations deliver after-hours urgent care and behavioral health service in both English and Spanish to their patient population. So a lot of these FQHCs are open from 9 to 5 and they're closed during weekends. So we help them, we help their patients get care before the clinics open and after the clinics close, and also during the weekends. And through behavior, we recently had the behavioral health services as well. So I kind of want to give, I know that a lot of you are familiar with this, but I kind of want to give an overview of the Latino community in California and kind of give some key statistics that kind of like give some ideas on how telehealth can be a game changing for Latinos. So as you probably know, by 2050, Latinos will represent 50% of the California population. Today, we have 15.6 million Latino individuals living in California. It's the largest in the states with the largest Latino community. 40% of the California's population is actually Latino, making it the largest group. And during the past decade, the Latino community has grown by 11% in California. Language preference. So I think this is extremely important, right? Because sometimes there's some wrong interpretation, but actually 38.4% of Latinos are bilingual, 36.4% speak language as a first language, and 25.3% speak English. However, 68% of Latinos speak Spanish at home. So this is an extremely important piece of data. And the other part is that 93% of Latino immigrants speak Spanish at home. So of course, for the immigrants, for the Latinos that came here, from Latin America, 93% actually speak Spanish at home, an extremely important data. Another important information is, the great majority, 88.3% of Latinos living in California are Mexican, 5.3% Salvadorians, and the other Latinos make up 6.4%, right? This is very different from other states, for say, let's take Florida, right? Where you probably have like a lot of Cubans and other like Latinos from like Caribbean and Latin America. Latinos are among they're actually the youngest group in California, and the median age is 29 years old, which is pretty in line with the average age of Latinos here in the United States. They're the population that has the highest workforce participation between men and women's. Also, like for women, Latino women are the second group with the highest workforce participation rate. The household size is around 44 individuals, and 31.7% of Latinos live in multi-generational households. Keep this number in mind because it's going to be extremely important later. So as I was telling you before, there's a lot of health disparities affecting the Latino community here in California. 38% of Latinos are underinsured or uninsured. 60% of Latinos have faced cultural language barriers. 32% of Latinos are less likely to receive mental health treatment compared to non-white Latinos. And only 6% of providers identify as Hispanic or Latino. So I'm going to link back to what Dr. Griffin was saying, right? We're already living a provider shortage. But when you look into the Latino community, the provider shortage is even more severe, right? So as Fierce Healthcare says, California faces critical shortage of Latino physicians. Only 6% of California's physicians are Latinos, right? So we live in a state where we have 40% of the population who's Latino, and only 6% of the physicians in California are Latinos. So there's actually a shortage of 54,000 Latino physicians in California to achieve parity with non-Latino physicians. And another alarming fact is that only 8% of California medical graduates are Latinos, right? So this doesn't show, there's no, the participation into medical school does not match the amount of Latino physicians that California needs in order to be able to improve and deliver more culturally competent care to Latino patients. However, I think that this map is actually pretty interesting because there's other states like Texas and Florida who have a lower percentage of Latinos that live in their states, but they have a higher percentage of physicians who identify themselves as Latino. So Florida is the highest one with 58.8%, and Texas is the second highest with 11.3% compared to the only 6% of California. And even again, citing back Dr. Griffin, the situation for mental health providers is even severe, as severe as if not more severe, right? So there's already a shortage of mental health providers, a big shortage, and there's around a 40% mental health provider shortage for the Latino community, right? So only 9% of clinical psychologists in California are Latinos. Only 21% of LMFTs providers in California are Latinos, and only 27% of other mental health counselors in California are Latinos. So there's nearly 1 million Latinos in California that are unable to receive mental health. And of course, the ones living in rural areas are extremely disproportionately affected. So how can telehealth really change the way that Latinos can access healthcare in California? So I decided to divide this into 5 categories, right? Because I really believe that addressing social determinants of health is really important when building a solution for Latinos, and this is what we have seen as we were building Akenta. So the 5 categories are adoption of user-friendly technology, the use of culturally competent providers, aligning patient and provider schedules. This is extremely important. Family and community support and coordination with the current health system. So the first one, adopting user-friendly technology. I'll give you an example. So initially when we started Akenta, we had an app, right? So you had to download an app on your phone to use Akenta. And we had a patient, she was an older patient, and she couldn't download the app, right? So, but she saw my number and she saw that I had WhatsApp. So she FaceTimed me on WhatsApp to ask me how she could download the app, the Acanta app. So I was like, this is extremely interesting, right? Because she might not know how to download the Acanta app and how to schedule a visit, but she does know how to do a video call on WhatsApp. So I'm like, we have to build something that is as easy or resembles the use of WhatsApp, because if this is, 52% of Latinos, they claim that here in the United States, they claim that WhatsApp is the most used app on their smartphone. So I'm like, if we can build something similar, we can make the experience much easier for people, right? And if then you look at the fact that 93% of Latino households claim to own one or more mobile phones, it means that the connectivity issue that sometimes there's a big myth. It's that really goes away, right? And the other interesting data that I saw is that 73% of Latinos have used their mobile phone to look for a health condition, right? They're among the highest groups. If you then look at the fact that during the pandemic, Latinos had the highest adoption of virtual mental health visits. Around 40% of Latinos claim that they tried to do a mental health visit, a virtual mental health visit. It really shows that this is a population that is really interested in using telehealth, especially to access healthcare. And if they can access culturally competent providers, they're more prone to use telehealth, right? And so I think, one important fact is being able to build a solution that is extremely user-friendly. There's a lot of fancy, cool technology out there that sometimes I think that you just gotta keep it easy. The easier you keep it for the patients, the more they're likely to use it. And the more you resemble an app that they're used to use every day, the more you'll have people adopting the solution. The other interesting part is that Latinos mostly own Androids, like 72% own Android, only 27% own iPhone, but in younger generations, this is swapped. So more of the young generation, more people use iPhone and less people use Android. So the second part is culturally competent providers. This is exactly why at Acanta we are building a fast growing network of culturally competent and bilingual Latino providers, right? So from the patient perspective, 33% of patients claim to prefer a Latino provider, and 81% of Spanish-speaking patients actually prefer a provider who speaks Spanish. On the provider side, I met many of the providers that I've met and have joined Acanta. They really do it out of their heart. They're like, I know the troubles that my community goes through when accessing healthcare. So if there's a company like Acanta that can help them, I'm the happiest person to do so. So we're seeing a lot of providers that are extremely mission driven, and they're extremely happy to be able to serve their community, right? Especially knowing of the shortage of Latino providers. The third part is at Acanta, we saw that nurse practitioners play a key role. They're more nurse practitioner compared to primary care physicians. They're more likely to speak Spanish, and they're way more likely to work in a primary care setting. So a lot of our providers for the urgent care, they're actually nurse practitioners. The fourth part is sourcing providers from other states. When I show you the map of the United States, as you could have seen, we have a lot of providers who are actually from Florida, but they're licensed in California. So this is something that you can only do with telehealth, right? And we all know that, as I was telling you before, there's of course within the Latino group, there's many different cultures, right? However, there's some things within the culture that are, they're similar between one another, right? For example, let's take the language, like the Spanish language. So what we saw is that we had providers that actually live in Florida, they're licensed in California, they're able to get connected earlier, right? Because they're 3 hours ahead. And this is something that if you had to do it in physically, you couldn't do it. So only telehealth allows that to do it. You can actually move resources around to try to close this gap that we have in California of Latino providers. The third part is aligning patient and provider schedules, right? We all know of the benefits that telehealth offer, but if you saw it before, I showed you how that Latinos are among the most active people in the US workforce. So as you know, as Diana showed before, the quote of the patient that said that thanks to telehealth, she could have like seen a provider during a break while she was at home, right? And this is extremely important. People are afraid to miss, don't show up to their job, take a day off to go see the doctor, right? Because this is going to create problems in their job, or if they work hourly, they're not gonna be paid that day, or they're gonna take their vacations day. So with telehealth, you can actually ease in so much this access, and also for the providers, a provider, maybe they're not able to see patients full time at Akenta, for example, right? But we have providers that are like, I'll work 2 or 3 hours a week with you guys during my free time because I like the mission, I want to join the mission, and also it's comfortable to me to to make some extra revenue working at Akenta. This is another part which is extremely important, right? The role of family and community engagement. Telehealth by itself it cannot be successful, right? There's a variety of things that we have seen that makes telehealth successful, a telehealth model successful, and that goes way beyond just the providers and the technology behind it. I call it, the family and the community engagement, right? So the first part, when I told you that Latinos live in 31% of Latinos live in multi generational households. This is extremely important because a lot of times are the younger generations that, they have access to information, they have access to the community, they have access to a lot of things, who then they bring it back home and they share it with their elderly, or maybe, somebody, the older person of the household is not as tech savvy, but the young ones are. So if their grandpa has to take a telehealth visit, they can help the grandpa, set up or get access to the link to the telehealth visit, right? And 27% of family caregivers are actually Latinos. The second part, it's local, the role of the local community. I always say that supermarkets must be involved. All the local organizations, they must be involved in promoting healthy habits and really get to know the community, what's out there. For example, when I was starting at Akenta, I would go supermarket here in Los Angeles to leave flyers on accessing Akenta. We were offering free visits, right? So, and people were, people at the cashier and all that, they were sharing it to the people at the supermarket to show, oh, how cool, there's a company offering care in Spanish for the people that need it, and there's no cost to pay for seeing a doctor. The third part is promotores de salud, right? A lot of you probably know about this model, but these people are key to the community. They're really the bridge between the health system and the Latino community, right? And nowadays there's some tech companies that are doing a great job. For example, Pear Team and Pear Suite. So what they do, they provide this software to coordinate care, because a lot of people, it's not just about accessing healthcare, but some people need access to housing, and some people need immigration survey, et cetera, right? Like food banks. So promotores de salud, they play a key role in the community, and the health system must engage them to be this gatekeeper with the Latino community, right? And the last part, I think there's another important part is coordinating. In order to build a successful model for the Latino community, there has to be coordination with the current health system, right? Because you can have the best community engagement, you can have the best technology, you can have the great providers, right? But if the health system doesn't buy into the solution, then you'll never reach the fair, right? I did a lot of, when I was starting Akenta, we did a lot of tests. I would tell people that the visit was for free and people would do it. And then when I would tell them they have to pay $30 for to see a doctor, people wouldn't do it anymore, right? And why do I say so? Because you need to, there's health, health plans like Medical, which are, for lower income individuals that are, they provide free, allow individuals to get free access to healthcare. But if solutions are not in the medical network, they will not get reimbursed. So, and this is also why we decided to build Akenta the way it is, because we were like, we don't want to be a competitor to any health center. We actually want to help them. We want to really fill in the gaps the healthcare might have because of the technology, because of the provider shortage, and really allow them to augment their services. So I think that a successful model is a hybrid model. You gotta use telehealth as a complement. You cannot only offer telehealth, you can only offer physical visits. I see the mix of both being the right mix. The second part is, as I was saying, reimbursement model. We gotta ensure that reimbursement model are sustainable, so that also organizations are motivated to keep offering telehealth and do not like remove telehealth services, which has happened in some health and clinics that I've heard of. And the third part, I know that we're moving towards a health information like exchange system. It's extremely important that all these solutions out there, they're interoperable with the current workflows, because if telehealth is not, requires more work from the providers, more work from the patients, more work from the organizations, people will not be motivated to use it. And the last part is, what I'm seeing is consider, partnering. I know that there's a lot of technology companies out there to offer great telehealth experiences. There's companies like Akenta who are tech-enabled, who provide clinician like network services. And what I see, like also to work towards this provider shortage, the best way to do is collaborate with each other, right? And kind of like revisit the whole part that maybe, you have a provider that only works at one place, but start splitting, providers between different clinics and try to do a better match of patient provider, right? So again, which role are we playing? We enable at Akenta, we enable organizations to offer great telehealth experiences to their Latino patients. We mainly have two products, right? One of them is the on-demand clinician workforce to extend the clinical teams. So where organizations like FQHCs, rural health clinics, or other like type of health system can access our providers who see patients in the name of the clinic in a completely white label form. The other part, we also offer some tech services to allow organizations to offer telehealth, in the form of audio, video, and also like chat support, where they can either use it with our providers, they can use it with their own providers. So that's pretty much it. I hope this was helpful, and this is my personal contact in case you want to continue a conversation. Feel free to reach out to me through the WOVA platform. And again, like I hope that we all work towards increasing health equity together. I've seen very interesting presentations. We had interesting conversation in the networking session. So I hope to stay in touch with many of you. And feel free to ask me any questions you may have.
Thanks so much, Marco. That was great. And as a provider who has done some telehealth, I think you hit the nail on the hammer when you said it needs to be interoperable and kind of moving along with the workflows and the processes. So it's not an extra 10 steps to get there. So hopefully we can make that more seamless in the future. We do have some questions. I'll start with the first one. What have been the top 3 barriers you have found to effectively reaching out to the Latino community? Trust issues, language issues, cultural issues?
I think the biggest issue was bringing everything together, right? It's as I was telling you before, we didn't have trouble in getting into the community. Again, we also we did some experiments, I would say, with using promotor distributed organization, with doing it ourselves. And I feel like getting the trust, that was not the hardest part we saw, because whenever they would know that the provider was Latino, or let's say for Spanish speaking patients they were Spanish speaking, I think that broke that barrier. But the biggest part was having patients coming to us and be like, I want to use Telehealth, but I'm not part of the we don't work with your health plan, right? Nor there's other people that were like, nor I want to pay out of pocket, right? And that's where we kind of transition our model. We were like, then why don't we partner with organizations that already have all that, and we help them enable that, right? It's like there's patients already, especially when you go into medical capitated models, right? Managed medical. I think that was the hardest trouble. So basically, it's really aligning all the resources together. I would say it's the hardest part, because from the patient, the response is positive, but then you gotta take into account also the economical part, which is hard to align all together.
Yeah, thanks for that. I think something else you said that I thought was very important is like aligning the patient with the provider to make sure they match and like establishing that relationship. So I think that sense of like community and awareness can definitely make one of these systems thrive.
Yeah, that's one of actually that's a dream I have. It will take a long time to get there because we need to really reach a big volume and we need to be present in every state. But what I want to do is being able to match. Let's say you have a patient who has Cuban descendancy, match them with a provider who actually has a Cuban heritage, right? And do it because, again, as I was saying, it's like there's some similitudes between Latin American cultures, but then there's some big difference. So getting to that point would be ideal. Of course, due to the provider shortage and due to the fact that you really have to get to a very large volume, it might take a bit, but we'll try doing that.
Awesome. Well, the future's bright. We have another question. I think it's an add-on to the first question. Are there noted technology barriers? Our agency has found some gaps with mobile device technology comprehension.
I think the WhatsApp example, it's important, right? It's the majority of Latinos living in the United States, they do have access to WhatsApp, right? And WhatsApp is, you can text, you can send pictures, you can initiate a audio call, you can receive an audio call, and you can initiate and receive a video call. So, and I mean, in Latin America, people actually buy things from stores through WhatsApp, and so there really, it's like, it goes back to the example of putting, I think a lot of people that have tried it, they said that, that the technology was hard to adopt because they didn't choose the right technology. And so I feel like the easier you keep it, and the less troubles you have. And that's what we have seen, for example, I mean, there's some patients that prefer audio calls. There's some patients that prefer video calls, and also there was somebody speaking about that earlier today. And I was like, really giving that option to the patient rather than, being like, yeah, of course, if there's something that I'm not a physician, but if there's a physician, that determines that they have to do a video call because of et cetera, okay. But what I'm saying, otherwise leave the freedom to the patient, right? And so I really think it's you don't want to add, the same goes for the patient. We all don't want to have 1,000 of apps in our phone, right? Because then it's like, if you have to do one thing with one thing with the other one, and then you won't use any of them, right? So I think it's really rather like trying to keep it as simple as possible, but as intuitive as possible.
So one thing that came to mind just with the use of like WhatsApp and it being kind of a social media platform, is there are you looking to kind of connect patient to patient that have similar diagnosis, et cetera, or is that?
So we haven't thought about that yet. That for sure helps. There's a lot of that can be done through that. We haven't gotten there yet because we didn't do a service yet for like chronic care management. That's something that we may want to add in the future, but today we're not doing that yet. But that's something that could be very interesting. And it's like, if you keep it in the channels they're already used to use, then you'll most likely have more success than asking them to go on a forum in a complete different.
Yeah, I think it's
app
like,
or page.
yeah, definitely. I think people are always looking for connection and people that have like things. So I think that'd be a great opportunity for folks. It looks like we are at the top of the hour. I don't see any more questions in the chat, but I will pause for a minute to see if anybody has something last minute they would like me to ask Marco. I don't see anything coming. So thanks, Marco. And I want to thank Claudia and Eduardo, if they're still here, for taking part in this session today. There was a lot of great information and insights shared. I think a lot of people will take away a lot of great things. And as a reminder, this video will be shared on YouTube later if you want to go back and rewatch.
Thanks so much.
Take care.